The lunch and learns were really popular. We moved one of the lunch and learns in here with Meet the Regulators, and I think we had about 140 people in this room. So I trust all the sessions today have helped you to even continue to ponder these great questions we're talking about and keep the discussions going. And I'm really excited to bring up our final keynote today. I know a lot of you are, to hear a lot around some of the science. Our afternoon keynote speaker, Dr. Susan Weiss, is the director of the Division of Extramural Research at the National Institute on Drug Abuse. She is considered one of NIDA's foremost experts on the complex science of addiction, marijuana science and policy, and the nation's prescription drug abuse problem. In addition to overseeing the agency's extramural research grant program, Dr. Weiss leads NIDA's involvement in collaborative research on addiction across the nation, the National Institutes of Health. Previously, Dr. Weiss served as chief of the unit on behavioral biology at the National Institute of Mental Health and as a senior director for research at the National Mental Health Association. So you're here to help us get some answers on science. Would you please help me welcome Dr. Susan Weiss.
So thank you all for being here. This has been really quite an exciting meeting for me, and my head is swirling with all of the discussion and all of the tremendous needs for research done now, or yesterday actually. I'm here to talk to you about the science, and actually you've heard a lot of the science throughout this meeting, so some of what I'm going to say you will already have heard, and I'll try and kind of go through those areas quickly. But I will give it to you from my perspective as a scientist, or as a scientist from an institute that supports research. And I'll tell you a little bit about some of the areas of research that we think are very important, and then I hope at the end that we'll have some time for questions and I can hear from you about areas that you would like us to pursue, or other ways that you think that NIDA might be able to help you as your states are implementing these policies. And I have to say, one of the things that's been so nice about this meeting for me is just the kind of basis for this meeting, that things are going to be discussed in a fairly, in an unbiased, even keel way, and we're going to deal with the reality, which is that this is happening, and we need to be able to find ways to make it happen with as few harms as possible, and perhaps benefits. So that is not a situation I often find myself in, and I'm happy to be here today. So I'm just going to start very quickly with the prevalence and trends, and this is something I'll really rush through because I know you've heard this many times. It's the most commonly used illicit drug, and you see I have the illicit in quotes now, given all of the changes in policy. About 22 million Americans, 12 or older, were past month marijuana users, and about 4.4 million Americans met criteria for cannabis use disorders in 2015, and it's among the illicit substances, it's the most common. We also know that about 2.6 million Americans used it for the first time, and 1.2 million were between the ages of 12 and 17. This is data from Monitoring the Future, which is a large national survey that NIDA has been conducting since the 70s, and it makes a point that, again, we've already heard, which is that we're seeing very nice declines in use in alcohol and cigarettes, but marijuana has remained fairly stable. This is in 12th graders. A few years ago, marijuana surpassed cigarettes in terms of prevalence of use. And I think that, we may be fortunate that the rates aren't going up, but again, this sort of gets us to the context of marijuana use among young people. I will say that the group that we're most concerned about are the daily users, and we have about 6% of people reporting daily use. And one of the caveats, and there's been a lot of caveats to the research that's been pointed out at this meeting, has to do with who is in this survey, and this is a survey that's done in the schools. And one of the things that we know is that heavy marijuana use is associated with increased rates of dropout. So it's possible that among 18-year-olds, the rates of daily use are actually higher than what we're reporting. So this slide is comparing Colorado data to the data for the entire United States. And I'm showing you these data to make just a few points. One is that most of the states that have passed have legalized marijuana for personal use or recreational use had higher rates of use even before legalization passed. This is the data from the 12 to 17-year-olds, and you can see that there did seem to be an indication of increases in Colorado, while it has been actually fairly steady or even decreasing across the country, but those seem to be leveling off now. And there's some arguments about those data because the National Colorado Health Survey does not show increases, but this is from a national survey that's been going on for many years, so I think those data are valid. We do know that among college-age students, that 18 to 25-year-olds, there are the people who use the most, and that has been going up. And what's very interesting, of course, is that we're also seeing changes among adults aged 26 or older, and you can see the very steep incline in Colorado when it became legal. And I'll tell you right now that one of the things that we really don't know a lot about is what are the effects of cannabis on adults or older adults, and this is certainly something that we're going to need to know more about. This is also something that was discussed yesterday by Jonathan Calkins, the fact that among the people that are using, they're also using it more often, more frequent. So this is just showing that among, between 2002 and 2015, there were more current users, but also there are more people that report using it daily or almost daily. And these surveys are not very fine-grained. I mean, you're not looking at how much they're using during the day. You're not looking at what the change in potency means in terms of quantities taken, and we heard a lot from Jonathan yesterday about why that may be very important. Again, we've talked about the fact that potency is going up. The studies, the increases in delta-9 THC that you can see on that graph are from seizures that the DEA made over time, and there's a University of Mississippi contract that analyzes it for us, and it shows that the rates have almost tripled. But this is really not even telling us what is actually out there in the dispensaries. This is seized samples, and we don't know what is actually being used out there in the dispensaries or in the states that are providing it for either medical or recreational use. And we've also heard a lot about the fact that people are using it in different ways, including orally, and that they're also being exposed in some cases to extremely high concentrations of THC through methods such as dabbing or shatter. And I think these are areas where we are really in the dark. We don't know what the exposure to this very high potency THC product is going to do to the brain and is going to do on a number of different functional outcomes. So just to sort of summarize some of the areas of research that we think are really important, we know that, I mean, the good news is that use among youth does not seem to have gone up, despite the fact that the perception of harm has been going down quite dramatically in this population. We also know that current users seem to be using more often, and that the potency is increasing and the plant components are changing over time, but we don't know yet what that will mean. Cannabis is being administered through different routes. We need to have better measures of frequency, dosages, and patterns of use. We need to have good messaging, especially for youth, and this has come up multiple times in this meeting, to counter the trend of decreasing harm perception. And these need to be messages that are credible and that have an impact. We also need to learn more about what the effects are of the regional differences based on the changing laws, policies, and social norms are a very important factor in use. And we need to understand better what's going on with other abuse substances. So again, coming to some of these adverse effects, we know a lot about them. We know a lot about the acute effects. We know what happens when someone is intoxicated. We know that it increases their risks of automobile accidents about twofold. We also know that it impairs cognition, it's harder to learn, it interferes with executive function or the ability to make reasoned decisions and not engage in risky behaviors. And with respect to its effects on moods, even though it can make people feel relaxed and euphoric, it can also make some people very anxious or paranoid and even create an acute psychosis. And this is often the case with either new users or with users of very high doses, and sometimes it's the case with edibles because of the fact that you can't titrate your dose, and it takes a longer time for the effects to hit you. But when it comes to long-term outcomes, I think this is what we're most concerned about, and we have some data. We have quite a bit of data that we've been collecting over the years, but it's very difficult to show causality, and there's a lot of reasons for this. I mean, one of the reasons is that we're not able to randomize people to exposure to substances, and so we don't know that the people who are using it frequently and who are having some of the ill effects that I'll show you in a few slides weren't different to begin with. Their brains may have been different, they may have had a lot of other risk factors that make them vulnerable to some of the poorer outcomes. We also know that young people who use cannabis often, and that's really the group that seems to be most vulnerable, also use other drugs, and it's very hard to dissociate the effects of these different drugs, and many people do this statistically, but that may not be sufficient. So we do have some research in animals, and I think that that's an important area for us to keep pursuing, but there's limitations there as well in the dosages that you can give and in the ways in which animals are given these dosages, but there's a lot of actually quite interesting data that's come from animal research. So we've been focused mostly on what we think of as the most vulnerable populations, which are really prenatal and adolescent, and that's because we know the brain is actively developing during those periods. And we also know that the system that marijuana acts on, which is the endocannabinoid system, is very important in brain development, both during fetal development when the nervous system is forming, and also in adolescent development when you're having changes in myelination as well as other kinds of developmental processes in the prefrontal, in the connections between the cortex and subcortical structures. So what a recent survey showed was that there are many people who don't perceive that using marijuana is harmful during pregnancy. It's a natural substance. It may help with their nausea. And that's true about 21% of Americans who think it's okay for a pregnant woman to use marijuana. And among those who are regular users, about 40% think it's okay if a pregnant woman does that. And actually, most of the states don't have specific recommendations against giving, for medical marijuana, don't have specific regulations against giving it to someone who's pregnant, although from everything I hear from everyone who's been here, that's pretty much on their radar, and I think that hopefully the policies are being enacted in ways that are not exposing fetuses to prenatal exposure to marijuana. So we also know that cannabis use during pregnancy is increasing. It's gone up, it's now at about 3% of women who are pregnant, and that just shows you a breakdown by age, 18 to 25-year-olds versus the 26 and older. So there's a small increase, but nevertheless it's an increase. What's very interesting and kind of disturbing is a paper that came out that was an analysis of all of the data from this National Survey on Drug Use and Health between 2002 and 2015, and looked at people who were pregnant and who reported using cannabis during their pregnancy. And in a way, it's not that surprising. Among 18 to 25-year-olds and 26-year-olds on up, the rates of marijuana use are lower among people who are pregnant, which are the darker green bars, than those who are not. But what you can see on the left is that the youngest people who are pregnant actually have quite high rates of cannabis use. And that may not be that surprising. If they're pregnant between the ages of 12 and 17, they're going to be engaging in a lot of risky behaviors, and cannabis is one of those. We also know that if you look across time, that the period of greatest exposure is in the first trimester. And we don't know if that's the most sensitive time, but we suspect that it could be a very sensitive time in fetal development. And it may in part be because people don't even know that they're pregnant and they're using cannabis. But it's certainly an issue of concern. So we don't know enough about prenatal cannabis exposure. What we do know is that cannabinoids can cross the placenta and they can accumulate in the fetal tissues, including the brain. And we know that the system, the endocannabinoid system, where cannabis works, is present during embryonic development as early as 16 to 22 days of gestation, which is the time when the nervous system is developing. There are a few cohort studies that are following children who were prenatally exposed, but there's been two that are long-term studies that started back in the 70s and 80s, but again, as we've already heard many, many times, the cannabis that was used then was very different than the cannabis that was used now. And the effects that they report are modest, but they do report some neurobiological changes or some higher susceptibility to conduct disorders, behavioral disorders, and early substance use. There is a cohort study now that's going on in the Netherlands, which is called the Generation R study, and that one I think is going to be very interesting. Those kids are now about 10 years old, and they've been following exposure to cannabis, and the cannabis in the Netherlands is about 15% potency, but the cannabis in the Netherlands is always combined with tobacco. So you're looking at a group that's been exposed to both nicotine and cannabis, and the comparison group that they look at are people that were only exposed to nicotine, and they do see some differences in brain structure. They see a thickening of the cortex. They see a slightly smaller birth weights during development. But again, we don't know exactly what this is going to mean functionally, but this is a good group for us to be studying and watching. There have been a couple of meta-analyses, and the data that they have, again, we don't have that much, but they do show that infants that were exposed to cannabis in utero have lower birth weight and are more likely to be admitted to the NICU compared to those without exposure. There's a lot of very interesting preclinical studies that have been done by Yasmin Hurd and her colleagues looking at exposure to THC and showing that in utero exposure or exposure during the period of adolescence, that changes the reward system, changes the vulnerability to heroin self-administration, and also may have a transgenerational effect where even if the animals are not exposed to THC during the time of pregnancy or in raising their young, there's actually a transmission of a different phenotype because they were exposed at a time when the germ cells were developing. This is a very interesting finding, but again, it's in rats, and we need to know more. But we are getting some very interesting data from animal work. So we need to know a lot about how cannabis affects neurodevelopment. What is the precise nature of the association? What are the factors that could moderate the effect of cannabis exposure? How do we quantify it? I mean, what are we looking for? Frequency, potency, route of administration? Are the effects that are seen permanent? Are there compensatory changes that happen in response to exposure? And how much do other variables contribute to whatever the cannabis effects are? And that includes other substances like alcohol and tobacco, but also prenatal care and even BMI and physical activity. And this hasn't come up a lot, but it's come up a little bit. We really don't know what the effects are of second or third-hand exposure to cannabis on the fetus, and we are starting to learn more about that with respect to tobacco smoking, and it does have an effect. So we do also know that the brain continues to mature into early adulthood, and so this is an area that there has been a significant amount of research on. And the research seems to be coalescing around the idea that people who start using early and who use chronically are at risk for a whole variety of negative behavioral outcomes. And I've already pointed out some of the caveats of this in terms of determining causality, but nevertheless there is this growing body of evidence that should certainly make us very cautious. There are a number of neuroimaging studies that have looked at how the brain develops in teenagers who are exposed to cannabis, and they've looked at structural measures, they've looked at connections between different parts of the brain, they've looked at functional measures, and the bottom line is that there are a number of findings that show differences between people who were exposed to cannabis versus those who were not. This one study that is illustrated here just shows that there was actually a very large change in the connections between two areas of the brain. It was very specific to only these two areas, but it was almost an 80% decrease in the connections between these areas of brain. So I think that I will say though that there are also some imaging studies that don't find effects of cannabis exposure, and one in particular, which was a very well done study, looked at the size and the shape of some of the structures that are subcortical structures, and found that that if you can match for alcohol exposure, then the cannabis effect tended to disappear, and the effects that they saw were attributable to alcohol. Now that's only one type of measure, but I think it just tells us that we need to be cautious. And I know that we want to have the answers now, but I do believe that adolescent use is fraught with risk, but we're not even absolutely there yet on that. So this is a study that you already saw from John Kelly. This was the study that was done in New Zealand. It was it's the Dunedin study, which is following kids from birth to age 38, and it showed a decrement in IQ, which was associated with cannabis use disorder diagnoses, and those who had more of these diagnoses, which would have been longer users, showed a greater effect on IQ. And this was one of the better studies because they had measures before people started using cannabis, and they were able to rule out a lot of different confounding variables, which are always problematic in observational studies. This is also a summary of, this is a study that included an analysis of 3 epidemiological studies that were done in Australia and New Zealand. And there are other studies as well that confirm this, but this does show that there seems to be an effect of early cannabis use on a variety of outcomes. It seems like it's a dose-related effect, so the more you use, the more likely you are to have difficulties. And on the left, what you can see is this shows odds ratios. The first one is cannabis dependence. No surprise, people who use a lot are more likely to be dependent upon it. Also other illicit drug use. Also suicide attempts came out very high in this, and I think that's something that we need to be paying attention to. High school completion is lower in people who are regular cannabis users. Same thing with getting a college degree. This study did not find any effect on depression. Some of the others have, but this one did not. And there's also a greater likelihood of welfare dependence. And this kind of finding has come out in a number of different studies. And again, all of these studies point to use early on, and when they define early on, it's usually before age 18. There's really not a lot of work on that period between 18 and 25 when we know the brain is still developing, and what actually are the risks at that time. Addiction, you know, I am still shocked at how many people absolutely refuse to believe that cannabis is addictive, and we've heard it here multiple times. This is an old study, but one of the reasons that I like this slide is because it shows you that for all of these drugs, not everybody who uses becomes addicted, and yet we would never question whether or not heroin is an addictive substance or whether cocaine is addictive, but we do with marijuana because about 10% of people become addicted to it, more if you start using young. And I think part of the problem is that it's so ubiquitous and people know lots of people that may not be addicted, and then there are a lot of people who don't admit that they are addicted, but really, or don't want to take less than they are taking right now, even though it may be interfering with their function. Again, this is something that we heard before. There is an association with psychosis. This is one of the strongest associations. It's come out in a number of different studies. There was a little bit of a discussion on this before. My reading of the literature is still that you have to have some sort of predisposition for this to do that, and that de novo psychosis in people that did not have any other risk factors doesn't seem to be the case. However, the studies do suggest that cannabis use is a component cause, which means it may be increasing the numbers of people who develop psychosis. It may be increasing the age, decreasing the age at which people start to show psychosis, and intensifying the syndrome in people that have it. So this does seem to be an important consideration, even though it may not be, it may require other factors besides just exposure to cannabis, including a genetic predisposition, as well as others. So what we know about adolescent cannabis exposure is that it adversely influences learning, it has effects on memory and attention, and these outlast intoxication. The effects appear worse with earlier age of onset, more chronic, more frequent use. Some, and actually most of the neuroimaging data support these effects. There's an increased risk of addiction if you start using as an adolescent. There are worse educational outcomes, career achievement, life satisfaction, and it's been linked with suicidal ideation or behavior. And it also is associated with an earlier onset or worse course of psychotic illness in vulnerable individuals. What we don't know is whether or not these effects are permanent, whether or not somebody who's abstinent for a long time will show a complete recovery. And I think that's one of the really important questions that we need to answer. We know that if you're using when you're an adolescent and you're not getting, you're not learning in school, then you're not going to be doing well, and you're going to be, so you're certainly maybe putting yourself kind of behind where you could be. But whether or not you can somehow make up for that if you do become abstinent, and whether or not the cognitive changes are not permanent but are impairing at the time, that's something we don't really have an answer to either yet. So one of the questions that was asked on the first day was about how do you look at some of these imaging studies, and how do you really know whether or not they're associated with cannabis? And we started this study about, it's going into its third year. This is called the Adolescent Brain Cognitive Development Study. It's a longitudinal study of about 10,000 kids that is a collaboration between many different NIH institutes. We have 21 research sites across the country, and we're recruiting 9 and 10-year-old kids that are healthy, normal kids, and we're trying to recruit them before they started using substances so that we can do brain imaging, we can do all sorts of behavioral measures to look at how they develop, what normal development looks like. I mean, we don't even really have an idea of what the variability is in normal adolescent development, and we're hoping that this study will help us understand that better. And by having a large enough sample, we can try and tease out the various trajectories, whether people are using many drugs together, whether they're using drugs and stopping, whether using occasionally has any impact at all, or whether or not you really need to meet some sort of critical threshold before you start to see the impairing effects that have been reported in so many of the studies. So we're very excited about this, and the other institutes that joined us are interested because there's also a relationship between mental disorders and substance use, and we can try and tease that out a bit more, which causes which make, or how do they interact. We're interested in physical exercise and exposure to screen time, so we have a lot of questions that we're asking, and we are very excited. We've got over 4,500 kids recruited so far, so we're well on our way. The other very important thing about this study is that it's going to be an open access data study, so we want people to be able to use this data and ask all sorts of questions, and we're hoping that it will help us get a better sense of what the real effects are of exposure, what could be mitigating factors, etc. So we've already heard that, we can't really deny the fact that there is some therapeutic benefits associated with cannabis or with cannabinoids. And I think that we're very interested in the potential of the system that cannabis works on. Cannabis is a plant. It contains 100 cannabinoids plus many other chemicals, and it's and almost all of the research that's been done at this point is done with THC, which is the main component that makes people high, or CBD, which is cannabidiol, and that's a very different constituent of the plant, and I'll come back to that in a few minutes, but I think we've heard about it. There's a lot of conflation in the media. When they talk about medical marijuana, they're often talking about cannabidiol because that's being used, or it's hoped to be, it's being used to treat seizure disorders in very young kids, and there's obviously a lot of sympathy for trying to help these kids that are in desperate shape. But most of the medical marijuana that's being used across this country is not cannabidiol. It's strains that are high in THC, but we'll come back to that in a minute. So one of the things that the science has come a long way on is we really do have a much better understanding of the signaling system that marijuana works at. And this whole signaling system was discovered because of researchers trying to understand how cannabis works. And we know that there are receptors or proteins that are located in the brain that THC binds to, and they're in a variety of different areas which are associated with the many effects that we associate with cannabis. It's important in brain development, in memory and cognition, in movement coordination, pain regulation, immunological function, appetite, motivational systems, and reward. Because of this, we think that it does have potential for therapeutic effects, but also for other harmful effects that we see. In addition, cannabinoid receptors are located throughout the body. And there are two types of cannabinoid receptors that are the main ones that are studied: CB1 receptors, which are mainly found in the brain and in neurons, but they are also found throughout the body. And then there are CB2 cells, which are CB2 receptors, which are found in immune cells, and they're mostly located in the body, very little within the brain, although there may be some. So I don't want to go into great detail about the mechanism of action of the cannabinoids. Jenny Wiley did presentations on that earlier, so I think for those of you who are really interested, I'm sure you heard a lot about it, expressed much more eloquently than I can do. But I just want to point out a few things. One is that the system has what are called endogenous cannabinoids, and these are cannabinoids that the body makes that interact with these receptors that THC also binds to. And I sort of wish I had a pointer here. What I'm showing is a cartoon of two neurons that are talking to each other, and the way in which the cannabinoid system works is that one of these neurons gets activated. It releases a signal to the what's called postsynaptic neuron that causes the formation of one of these endogenous cannabinoids. So it's kind of made on demand based on the cell being active, and it feeds back to the neuron, to the presynaptic neuron, and it dampens subsequent activity. So the effects of these endocannabinoids will depend upon the neurons that they are located on. They're found on excitatory neurons, on inhibitory neurons, but it's a modulatory system, and it's very finely controlled, and there are enzymes that will then break down these endocannabinoids so that the system is functioning properly. And my main point here is that a drug like cannabis or THC will affect this system in a non-physiological way. So it will affect all of the cannabinoid receptors throughout the brain, and it's not broken down in the same way. And it's this repeated exposure to something that is not physiological that causes some of the adaptations that we see in the brain, and also causes some of the longer-term effects that we see. So when we think about ways of trying to take advantage of the therapeutic possibilities of the system, there are other ways of doing it that are more selective and that maybe have a more nuanced approach, which may actually have a better therapeutic effect. And one example is something that's called an enzyme inhibitor. So these are called Pha. One of the enzymes that breaks down the endocannabinoids is called Pha. And if you block this enzyme, then what you do is you facilitate the endocannabinoids' actions within that particular circuit that's being activated. And there are people that are working on this that have looked at it in a variety of different animal models. And it's hoped that by having this more selective and subtle effect on the cannabinoid system, you may be able to take advantage of some of the therapeutic benefits without some of the adverse effects, including tolerance and including some of the other, the risk of addiction, etc. And there are a number of different ways of affecting this system. This is just one example. I wanted to come back to Delta-9 THC versus CBD. Some of you are from states that have only passed laws that allow CBD, high CBD forms of cannabis, and most of those have very low levels of THC in them. And cannabidiol is a very interesting compound. It's still Schedule 1 because it comes from the plant, but it doesn't act through the same receptors. It doesn't act through the cannabinoid 1 or cannabinoid 2 receptors. There's a number of different potential ways that it may act, and we don't really know how it does what it does. It does not have rewarding effects, and it may even counteract some of the effects of THC. And in fact, most of the high-potency cannabis that people are using has very low levels of CBD. It's been bred out of the plant because it may, in fact, counteract some of the THC effects. But there's also some hope that it may counteract some of the, the potentially negative effects, and that it may actually be, there may be ways of fooling around with the levels of CBD and THC in a plant that could make it actually a more effective either medication or even for use recreationally that may make it less dangerous. And it has, it has promising effects in childhood epilepsy. And there's a company, GW Pharma, and there's actually another company, Insys. They're working on pharmaceutical formulations of cannabidiol. Epidiolex is the one it's pretty far along in clinical trials. Don't worry about all the details. The main point here is that it does seem to reduce seizures in children with these very severe forms of epilepsy, like Dravet syndrome. Doesn't work in everybody, isn't a miracle cure the way it was first described by Sanjay Gupta, but it may have, which started quite a whole lot of, and he's one of the worst offenders because he calls cannabidiol medical marijuana, and I think that, the people who are really pushing for this, really love the fact that these two things get conflated, cannabidiol and the other types of medical marijuana that people are using. So I think there's something there, and I think we're all very anxious to see the results of this, and we're hoping that this will become approved as an FDA medication. And it's an extract from the plant, but it's a purified extract, and there will be known dosages, which is what you want in a medication. So we see the cannabinoid system as a very exciting system for therapeutic purposes, and there may be many ways in which we can take advantage of that, including using some of the plant-based cannabinoids, synthetic cannabinoids. There are already a few that have been approved, and then other ways of manipulating the system, such as manipulating the enzymes or manipulating some of the receptors that I mentioned that are affected by cannabis. So the last part that I wanted to talk about is policy, because that's what this meeting is about in large part, and I think that, we want the science to influence policy, and we already know that there are many, many caveats and much information still needed. Policy is very complicated and it's moving fast, as I don't have to tell you. Right now, there are 29 states with medical marijuana laws. There's 17 states with cannabidiol-only laws and 8 states with recreational cannabis legalization. And they're all implementing these in different ways, and we've heard about that from some of the speakers here at this meeting. And I have to say that's one of the things that I've really enjoyed most, because I'm kind of, I know it's happening, but really hearing what's happening on the ground and what people are contending with and what they, how little data they have to guide them is really very eye-opening and frightening. And especially since everybody here, I think, really is very concerned about the public health. So this is an old slide. There are at least 51 medical conditions for which marijuana is approved by a state. We heard on Monday that there's some 267 conditions where cannabis may have a beneficial effect, even though there's more conditions than there are medical conditions. But I think that, one of the ones, so for many of these there's just no data whatsoever, and it's really all anecdote. Somebody thinks it's helped with this, and the studies aren't there either way. But I wanted to come back to pain, because I think that's a really important one, and it sort of exemplifies the problem that we're dealing with. The National Academy's report said that one of the strongest evidence for the effectiveness of cannabis has been in treating neuropathic pain, or pain associated with muscular dystrophy, multiple sclerosis. And there's been a number of different meta-analyses, and there keep being these reviews that come out, and they all seem to say the same thing, that there's generally a positive effect, but it's small. And it's most of the studies are not done with the plant material. They're done with the different cannabinoid formulations. A lot of them are done with things like Sativex, which is an extract that contains both THC and CBD. Some of them are done with Marinol, which is an approved substance. But all of these studies are short. They're small. The effect sizes are very modest. And then there are problems that we've already heard about, like how do you blind subjects to the condition, to the treatment that they're getting, and how much is the placebo effect. But at the same time, I will say that just having so much consistently positive findings is in itself suggestive to me that there's obviously something that's really there. And there's animal research that supports the fact that if you affect the cannabinoid system, you can affect the sensitivity to pain. So, I don't want to minimize it. I just really want to say that we don't know enough yet about what kinds of cannabinoids, what mixtures, all of those things, and how it would best be administered. But at the same time, we are really in an urgent situation. We have 100 million people in this country that have pain conditions, and many of whom are not being adequately treated, and many others are being treated with opioids, and we know that we all know about all of the horrible things that are happening with opioids, which I do want to say not all of the overdoses and everything else are pain patients, but nevertheless, this is a really important issue for us to deal with, and it would be nice to just say, well, just wait, because we will have these medications for you in the next few years, but we really can't do that either. And there are these very high-level studies. They're not looking at an individual level, and I think you need to interpret them with a lot of caution, but they suggest that states that have medical marijuana laws and dispensaries show decreasing overdose deaths associated with opioids, fewer opioid treatment admissions, more cannabinoid use disorder treatment admissions, and also an analysis of both Medicaid and Medicare data showed also that prescriptions are lower in the states that have medical marijuana laws versus those that don't. And if you look at what the prescriptions are lower, the prescriptions for opioids are lower, and it's especially true for pain. And then there is more and more, there's a lot of anecdote. There are a couple of surveys that have come out in which patients are reporting decreasing their opioid dose because when they start using cannabis. So there's something here that is really important, I think. But the way in which this is happening is really kind of a disaster. You don't send somebody to a store and say, pick out your opioid. You could take poppy seeds, you could take morphine, and that's what we're doing here. And we're also putting physicians at a disadvantage because they don't really know what to advise their patients. They don't necessarily know all of the risks and harms and who's going to be most vulnerable to those things. So we're really in a very difficult situation, and I don't have an answer, I think, but I think that we need to keep thinking about all of these things together because they're all interacting. So my last couple of slides are, this is something else that we have started, that we've talked about, and I'd be happy to talk more about it if you want to. It's really very disturbing, and it has to do with the barriers for doing cannabis research. And the biggest one, I think, is what we've already heard, that it's a Schedule I substance from the federal level, and that makes, and people can get Schedule I licenses, and they can do research with Schedule I drugs, but it's difficult, it's very complex, it's very lengthy. We've talked to pharmaceutical companies that say it takes them a year, and they've all got the lawyers, and they know exactly what to do just to get the licenses. And there's federal DEA agents, there's local DEA agents, there's all sorts of things. These applications are put in paper. They're not even electronically available yet. So that's a problem. The other problem that was mentioned once, but this single source thing. So this was an interpretation that the DEA made of an international treaty, and which says that all cannabis that's being used in research has to be controlled by one agency. And so they took that to mean that it has to be one source, and they made us the lucky winners to be the farmers to provide the cannabis for all research. We've tried to diversify our products. We now have different levels of THC and CBD, but we cannot compare with the sorts of products that are out there in the dispensaries in terms of the variability in what they contain, as well as the different formulations that are available. So in August, when the DEA denied the petition to reschedule marijuana, they also said that they would allow other growers of marijuana, and they were going to be accepting applications for that. And I think there's been something like 25 applications that have come in, and nothing has happened. NIDA would be really, really happy if there were other growers. We don't have more money to put into this, and we think it's crazy to not be able to take advantage of all of the various things that are out there. So there's a lot, so we would really like to see more suppliers. We think that would make the potential for developing medications much greater, because then they would be able to make the kinds of formulations that they want, and we also think we would get answers a lot quicker. The other thing is, cannabidiol is a Schedule I drug, and that's just, because it comes from the plant. I mean, it really doesn't make a whole lot of sense. There are a lot of scientific barriers that make it difficult. It's a plant with 100 cannabinoids. It's very complex, and people have argued for an entourage effect. And meaning that it's not just the THC or it's not just the CBD, but it's some combination of either various cannabinoids or various other chemicals in the plant, terpenes or something else. We don't really know. There's really no evidence for this entourage effect. But again, it makes it a very difficult thing to study because you have to really determine what it is that you want to be looking at. The route of administration, obviously smoking is not a good route of administration for anything, since exposing the lungs to smoke is not a good idea. And then, you know, finding proper controls and doing studies that are of sufficient duration. Most of those pain studies that I mentioned they go for a few weeks, some of them a day, and maybe at most a month. So, you know, people with chronic pain are living with this for a very long time. And we're not taking advantage of what is already happening in the States. We don't have patient registries. We don't have knowledge of exactly what people are getting and what they're using it for. And this is heartbreaking because, you know, this is happening now and we should be learning from it. It's going to take a long time to get all of the randomized clinical trials done, you know, to look at all of these different conditions, but we could be doing this right now. We aren't allowed to analyze the marijuana that is in the States because we would not be able to purchase it with federal funds. So the federal-state differences are really not helpful in our trying to move this along, and the legislators are very interested. I mean, we've gotten calls from many states that have passed laws, and they really are serious about wanting more research. I wish there was more research funds devoted to it when I've been hearing kind of the amount of money that's coming in and what's going to research. It's not a whole lot. But I think that, you know, so they want it, and in fact some of the states have passed laws where they want the growers and the manufacturers to work with the universities to do some of the studies with their product. The problem is that the universities can't accept the product because then they risk losing their DEA license. And so there's a lot of barriers that we're trying to work behind the scenes. We're trying to work with, you know, with the FDA, with the DEA, as much as we can. But these barriers they're still real. They're still there. And with this particular Department of Justice, we don't know that they will be eased at all. We'll see. So policy conundrums, you know, we know that legalization is happening, you know, in most states, but there's still a lot of uncertainties because of the fact that it's illegal under federal law. We also know that science is lagging behind policy, and policymakers are looking for data to help guide their decisions. We know that health messaging has to be nuanced and accurate, and discussions about cannabis rarely are. Scientists tend to be more conservative in their messaging than advocates. They tend to know all the caveats and know all of the little holes in the research, and they don't tend to come out with the same sort of strong messages that many of the advocates do on either side. And it's very hard to control messaging anyway. Even if the marketing of products is restricted in all of these states, there's all of the social media and there's all these other ways that people are getting information that's very hard to control. We also know that substance use is affected by availability, cost, perception of harm, and that doesn't just mean health harms, it also means risk of criminal penalties, and that perceptions of harm are decreasing across all age groups. The two currently legal drugs that we have, tobacco and alcohol, are the most costly to society. And it's not because they are necessarily the most dangerous drugs, but it's because they are the most widely used over the longest periods of time. Societal norms influenced use. Tobacco use, even though it's legal, is going down. And that's, you know, tobacco has been stigmatized. The tobacco companies are hated by everybody. We've already heard about that. And I think that marijuana, you know, we also heard that from Jonathan. Marijuana users love the marijuana industry. So with no federal oversight or guidance, states are implementing diverse policies, and they don't have access to a lot of the regulatory mechanisms that they would have with federal oversight. So my final slide, the challenge I think that we're all facing is how do we minimize harm in an environment where policy decisions are outpacing research and knowledge. And I think it's important to identify what we do know and what we don't, and then to prioritize research needs. Obviously, I'm talking as a research institute, but I think there are many health research needs that we need to have a better sense of. Policy research, NIDA has a cannabis policy research working group that John Carnevale is leading for us as part of our council, and we're trying to come up with some ideas for priorities for NIDA for research in the coming years. And obviously surveillance is crucial, and we've also heard about that. We need baseline data, which we don't have. And we also need to figure out what are the most important things to be looking at. Maybe just use is not enough, but really problematic use, or ER visits, or accidents, or achievement in school, and you know, workplace problems. And finally, I think communication. We really have our work cut out for us, because we need to have credible and persuasive messages for the public, for the medical community, and for policymakers, and we need to have these now without all of the data that we would like to have behind them. So that's it. I'd be happy to take questions.
Susan, do you have a sense of NIDA's agenda, so to speak, in terms of its research agenda, given the limitations that have been put upon you in the next year and a half, as it relates to cannabis research? Because certainly one of the things that has come out of this conference in the last several days is research, and a little bit more research.
Yep.
And perhaps we should start doing some research. And so the call is on, and you can see that the states have limited resources. In what resources they do have and what they have devoted are infinitesimally small.
Yeah.
So the question is not the large estimates necessarily, the dollars, and I think we all realize the barriers associated with trying to do this, but at least if we could get a sense as to some of the key questions that NIDA wants to take a look at, or is looking at, or will be looking at, given the barriers, would be great.
So a couple things. So one is that we don't have a political agenda, but we do have a mission, which is to study the effects of abused substances. And so the medical uses are not our priority, except as it relates to pain, because there may be alternatives that are better than opioids, or there may be cannabinoids that could actually be useful in treating cannabis use disorders or other substance use disorders. So other NIH institutes are slowly picking up the pieces in terms of some of the other types of potential medical uses. For example, epilepsy would be studied by the National Institute of Neurological Disorders and Stroke. So within NIDA, we do a lot of work on the basics, the basic cannabinoid system and how we can exploit it for different types of therapeutic purposes. We also are doing research on trying to come up with better treatments for cannabis use disorder, and we made that a priority. We had a special RFA for medications development for cannabis use disorder. The ABCD study is a very major investment in our part, and in part was really spurred on by the fact that these laws were changing all over the country, and we just don't even know what we can, how to advise people. But we're open to ideas, and then that's really why we also so we're interested in a variety of health effects. We're probably not going to look at the effects on lung cancer. That would be something that the Cancer Institute would look at. But we look at a lot of the brain effects, a lot of the neurological effects, some of the effects on other mental illnesses, and we formed this working group to try and help guide us on priorities for policy research. And so we're hoping that we will have a report that will be available by February, if not sooner.
You talked briefly about the prenatal effects of cannabis. I'm curious about the effects on sperm. Is there any studies out there on sperm count, maybe duration, 6 month off, 6 month on? Is there any information out there that is talking about count, flow, these types of things?
So there is some, it's not research that I'm that familiar with. There are effects on embryogenesis, there are effects on spermatogenesis. I know that, but I don't really know that literature so well. There's also these effects in animals where exposure to THC of the paternal side, the paternal parent, as well as the maternal parent, can produce some of the changes that are seen in the next generation. But that's really, those may be effects through what are called epigenetic mechanisms, because there are endocannabinoid receptors that are in the testes, and that so somehow or other these endocannabinoids may be able, or these THC exposure may be able to do something to change the germ cells, which then get translated onto the next generation. But I could, if you write me, I can get you some papers on it, but it's just not an area that I follow that closely.
I've been participating in the prevention track, and one of the sessions talked about, they started with 38 evidence-based practices, and they narrowed them down to 10, and then they narrowed them down to 8 evidence-based practices that have shown a reduction in perception of harm. And of course, they're very old, they're about in their life skills, the ones that we all know, and the data is just very old. It's neither looking at investing and increasing some of the prevention programs that are just way outdated.
Yeah, I mean, prevention is critical, and it's especially critical as these laws are being implemented. Most of the NIDA investment in prevention has been in the kinds of programs that you mentioned. They're broader, they're not necessarily targeting marijuana, they're really just targeting life skills and other sorts of behaviors to be able to encourage that. So it's something that we are still investing in. I haven't seen very many, marijuana-specific prevention programs that have come in as applications. So it has not, it has not really. So prevention is important, and we're trying to look at it, and we look at, and I know NIDA's been criticized for this, but we look at prevention very broadly, and so we look at sort of the many factors that are associated with risk for becoming addicted, and that's again where some of the studies like ABCD and some of the other work that we're doing to just understand brain development and risk factors for problems with cannabis and other substances. That's also part of our prevention approach. But as far as the prevention programs per se, I just haven't seen very much come in that are really targeting that. And most of the prevention programs are much broader, and they seem to have broad effects. I mean, they seem to have effects on prescription drugs and on marijuana and on other things. But I think we need to, the other part that was discussed here as well by one of the other states is just that, the messaging that we need to do in the states to, we need to study. I think that's an area that we really need to put more of an investment in to see what works. Because, we certainly know that telling somebody that, 30 years from now you may not be the professional that you thought you would be is probably not going to stop somebody from using marijuana right now. Or, that you're going to only be, your IQ is going to be down by 2 or 3 points, So we need to find what the right messages are, and I think that trying to take advantage of what the states are doing to try and prevent marijuana use by minors, even though it's also illegal, I think we should be doing research on that as well.
We have a question here.
Hi, I had a question about funding for clinical effects. Like, is it just the molecular changes? I'm right over here, sorry. Thank you. Or are you also willing to look at some of the perceptive clinical effects? And I had
I'm sorry. Could you back up?
Yeah, I had a question about the effects of cannabis.
Yes,
funded by NIDA.
Yeah,
and whether you're just looking at it on a molecular level, or would you be willing to fund clinical effects in terms of what's reported by patients?
Yeah.
And then I had a second question, a follow-up question.
Yeah, no, we are interested, and I think, that's why I even mentioned, the idea of registries. I think something like that, we would be willing to fund that sort of thing. The restrictions that we have are that we can only use our marijuana if you're giving it to someone, but if people are already in programs, if they have access to cannabis and they're using it for different things, the more information you can get about what exactly it is that they're taking. But I think we are interested in whether or not it would have therapeutic benefits in that way. So it's not just the molecular. I mean, we're interested in the basic science, but we are also interested in the clinical science.
Okay, and then the second question was to, I guess, get more money for research. The president seems to to look good, and he doesn't mind bucking his administration as well. So, and he declared a national emergency against opiate use. I'm wondering if this would be a great climate to present to him to increase funding for cannabis research and the effect of cannabis to use, since we already have some data that it is promising to get people off of opioids.
Yeah, it's interesting. So the president finally declared an emergency, but that really still has not translated into additional money for us. And you've heard Jeff Sessions kind of made the point that cannabis may be driving the opioid epidemic, and then got a lot of feedback from scientists saying there's also all this other data that suggests that it may actually be useful for ameliorating some of the effects of the opioid epidemic. So I think it is a good time, but right now we haven't gotten any extra money for doing research on opioids yet either. So if we do, I mean, again, this is really one of the top priority areas for us, opioid research also. So I think we would certainly be interested in looking at that and looking at whether or not you can decrease opioid use, or even get people off of opioid use, or affect, whether it's for pain or even if they are using opioids, if they're just abusing opioids because they are opioid users. So I think that it is of interest. Oh, I'm sorry.
The reason why
This is
cannabinoids, they're already FDA approved, like Marinol, why they're not being studied?
So I think that they are being studied. I mean, Marinol is available, and it has been available for a while. And again, we would be interested in studies that want to look at Marinol as a way of looking at, as an alternative for opioid use. So that would be an interest. I mean, most of the research that NIDA funds is investigator initiated. So we have to get the projects, and they have to score well in peer review. And we have many program officers who would be very happy to work with any one of you who is interested in doing a research project and putting in a research project, because this is an area of interest. But certainly, Marinol can be studied by, Marinol would be one drug to look at.
All right, can we give it up one more time for Dr. Stephen?